Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of a 60-year-old male who presented to us with complaints of generalized body ache and hematuria.
Okay.
So, sir, there was a 66-year-old male patient who presented to our ER with complaints of generalized body ache and along with this some lower abdominal pain and hematuria, he said, since about 2 days. But the thing is, he had generalized mostly on the proximal muscles more than the distal ones, but there was no neurological deficits as such, but muscle tenderness was present.
Okay.
So with this complaint, he had come in. For the last 2-3 days, it had increased. Previously he had aches, but it had increased, which is why he got to the hospital. So in our initial 10-second assessment, patient was conscious, oriented and obeying to our commands. Moving on to the primary survey, airway-wise, patient's airway was patent and no secretions or anatomical deformity was noted. Breathing-wise, he had adequate chest excursions with adequate chest rise, no respiratory muscle weakness that was noted. Air entry was bilaterally equal, chest was clear with respiratory rate of 18 cycles per minute, maintaining saturation of 97% in room air. Then circulation-wise, he had a blood pressure of 130/80 and a heart rate of 84 beats per minute. All peripheral pulses were palpable and regular in rhythm, the pulse nature. Then disability wise, he had a full GCS score of 15/15 with pupils being bilaterally equally reactive to light, symmetrical, but no neurological deficits. He was able to move even though he had pain. He was able to move, but he wouldn't prefer to move because of the pain that he had. And then exposure wise, he had a GRPS of 116 milligram per deciliter and he had normal body temperature. So there was no adjuncts to be used at this point in time. So we moved on to the sample history. Now in sample history, he was a known case of CAD, had a previous twice STEMI, and whether he was thrombolized or not, we don't really know because records of that is not available. And he has a severe LV with an injection fraction of only 26% and severely hypokinetic heart. And then triple vessel disease. He was advised CABG, but patient was not willing for it, and he was planned for PTCA this month, last week.
Okay.
So along with this, his other comorbidities includes diabetes mellitus, dyslipidemia, hypertension, CLD, and CKD history with last creatinine was 1.9. And moving on to his medications, he was in Brilinta, that is ticagrelor, 90 mg BD. So along with this, Ecosprin, 75 mg. So he takes dual antiplatelets. Along with this, he was on high dose of rosuvastatin, 40 mg he takes in the night. Along with this, Lasix 40 mg, Cardivas BD 3.125 mg, and then Mixtrid 30/70 that he takes.
Okay.
So these were his medications. But in the presenting complaints, apart from generalized body ache, he did not have any fever history. There was no history of any recent trauma, no altered sensorium or altered behavior, no chest pain, no breathing difficulty, no loose stools, vomiting, hypokalemia. On evaluation, he had hypokalemia,
Okay.
but he did not, history-wise, there's no history of vomiting, cough, nothing of that sort. And family history, nothing contributory. There was no autoimmune disorders also in the family. Apart from these comorbidities, he did not seem to have anything else. So moving on to the clinical examination, systemic examination was pretty much clean. He had a normal bulk, so there was no muscle wasting also noted, but muscle tenderness was there, mostly on the proximal, but symmetrical muscle weakness, mostly on the extremities, lower limb more than the upper limb. And along with this, other CNS examination, all the other rest of the examination has been clean. Then there was no rashes also noted, no skin changes, pigmentation, nothing of that sort was noted in this patient. And then we had to evaluate investigation wise. So VBG did not show any acid based arrangement.
Initially, when you examine this patient, what will be your differential diagnosis?
One, since he did not have any fever history, all that, so inflammatory causes were little It was kept in the background, sir, but it was
Infectious
not the DD.
causes.
Infectious causes, but he did not have any fever history as such. But he was on a high dose of rosuvastatin. So statin-induced myopathy is quite common.
Okay. Not very common, but statin-induced myopathy can occur. So that is one differential diagnosis.
Then he's elderly age, so malignancy has to be thought of.
Okay, polymyositis,
Polymyositis.
secondary to malignancy.
Then hypovitaminosis D.
Vitamin
can cause
deficiency can produce proximal myopathy, painful. Then
Then there are other DDs for polymyositis, sir.
diabetes. Diabetes induced
myopathy.
proximal painful myopathy or plexopathy is also common, but that is mostly asymmetrical. Here it is symmetrical.
Symmetrical.
And infectious causes.
Like Wheel syndrome and all can cause
Okay.
myositis. So these were the DDs, sir.
Okay.
So in VBG there was no lactate elevation. It was like normal but on the higher end of normal, 2.0. No acid-base derangement. And he had metabolic alkalosis, 7.46 pH with the PCO2 48. Bicarbonate was 30.6. And he had an associated hypokalemia with the potassium levels of 2.9.
Okay.
And creatinine was 1.6, but considering his last creatinine, it was low. So there was no acute kidney injury as such. And rhabdomyolysis had to be thought of, sir, but patient does not have any hyperkalemia. But such acute pain, rhabdomyolysis has to be kept in mind. If not now, then probably it can progress.
Okay.
Then GRBS was 117 milligram per deciliter. X-ray did not show any infiltrates, no patches.
What do you want to see in chest X-ray?
Any infective causes have to be ruled out.
It is mediastinal lymph nodes, malignancies,
Lymphadenopathy.
or malignancy in the lungs, rib erosions. All these things are very important. Because old age myopathy mostly indicates a malignancy, especially lung malignancy, polymyositis.
He had normal parenchyma. Even on auscultation also, he had normal vesicular breath sounds.
Okay.
Then ECG wise, he had a normal sinus rhythm, but some changes of incomplete LPBP was noted.
Okay.
And he had concentric LVH, that left ventricular hypertrophy signs were there. So along with this, we did a 2D echo. 2D echo confirmed the previous findings of severe LV with RWMA with severely hypokinetic heart.
Okay.
So he had a global hypokinesia rather. So along with this, when we sent for, and they said it was a lower abdominal pain with hematuria-like features. So we sent for urine routine just to rule out a UTI, but even on visualization, it was a dark-colored urine, sir. It was not hematuria. Urine routine came back clean.
How do you differentiate from a blood in urine, that is hematuria, from hemoglobinuria? Is it possible?
There will be sediments of RBCs.
Normally, if you keep for some time, there will be sediments. But whereas in hemoglobinuria, myoglobinuria, you may not get it.
So it was more like a dark colored urine rather than hematuria, and urine routine confirmed it. There was no blood or RBCs that were detected. Bacteria wasn't there, and patient's prostate size also was normal on ultrasound. So UTI was not really thought of at this point in time. And because we were suspecting statin-induced myopathy, we had sent for total CK, and patient also complained of lot of muscle tenderness. So total CK came back to be 1,40,000. That is like more than 10 to 20 fold of normal CK. And so he, along with this, our urine myoglobin which was sent came back to be 3+ positive. So patient had myonecrosis ongoing, but rhabdomyolysis as such was not there. Potassium correction was given and vitamin D correction also started. And we started the patient on IV fluids, but it is a tricky thing because patient has a severe LV. So we had to watch out for any signs of fluid overload. But as far as patient was able to tolerate, we gave patient fluids. And then along with this, urine output was monitored hourly, and fluid, it was titrated accordingly. This is how we went ahead with
statin. Suppose this patient creatinine increases, how do you manage? This patient is having myopathy. Whether it is inflammatory myopathy, statin-induced myopathy, whatever it is, he is developing rhabdomyolysis. If creatinine increases, how do you manage?
It will be secondary to myoglobin, sir.
How do you manage?
So fluids again.
How do you give fluids? This patient is having cardiac failure, so how can we give fluids? You give Lasix along with continuous Lasix infusion with fluids. There is no other choice because he is having cardiac failure and diabetes is there. If myoglobin itself can produce aggravation in the renal parameters. So if we want to give fluids and start Lasix. That can remove the fluids. And we have to be very careful when we are giving fluids because patient can develop hypotension, pulmonary edema, all these things. Okay.
And statins were stopped.
Okay.
And since the initial management was stopping the statins and seeing if the patient's total CK is coming down or not. Because if at all it is not coming down, then other DDs have to be thought of, especially malignancy has to be thought of. But in this patient, our initial suspicion was right because on serial total CK monitoring, from 1,40,000 to today's count being 97,000, it is coming down.
Okay.
And all we did was just stop statins and monitor the patient.
What are the alternatives for statins?
We can give as ST-MIB.
What is the action of ST-MIB?
It is again that cholesterol.
It prevents absorption of cholesterol. Okay, then
nicotinic acid also can be given, sir.
Okay.
But nicotinic acid along with combination of statins, certain trials say it will cause myopathy.
It can also produce myopathy.
But just giving a lone treatment of nicotinic acid is not proven yet.
Okay. Can we give fibrates? Fenofibrate.
Fibrates again can cause
that
myopathy.
Also can produce, but when it is combined with the statins, there will be increased amount of myopathy. Okay.
And then now among the statins, the highest risk statins will be atorvastatin, simvastatin and lovastatin.
Okay.
And the lowest ones which we do not commonly use is fluvastatin and pravastatin.
Okay.
Rosuvastatin, it is not notorious to cause, but in high doses like this patient, it can cause, and especially if the patient is a high risk patient, meaning the patient has an underlying hypothyroidism, hypovitaminosis D, CKD, CLD. In those cases, patients are more prone to cause myopathy. And certain genetic, that metabolization of statins, those enzymes, if that is variation in that, some people will be prone. Genetical.
Okay.
That metabolization, that like CYP, something like that. Those people will be prone.
Okay.
And then if the patient is taking other drugs like glucocorticoids along with it, colchicine, your ARTs like Zidovudin, all these in combination also can worsen.
Then Zidovudin alone can also produce myopathy. Steroids can produce myopathy, but they are not. Steroid alone produces myopathy, not myositis. Okay.
So then,
but whereas Zidovudin produces myositis.
Then colchicine, cyclosporin, all these drugs have to be watched out for. And patients, any drug interactions also has to be kept in mind. And generally we suspect this when the patient presents to us with symmetrical proximal muscle tenderness with underlying risk factors and symmetrical, basically proximal and symmetrical. So this patient presented with all of this. And
potassium, what happened?
Potassium, it was initially 2.9, sir. So it was aggressively corrected because then patient with hypokalemia, he can also end up with constipation, paralytic ileus, because he also has myopathy and all of that. So that was also aggressively corrected. So at present, it has come up to 3.8.
Okay.
But we didn't want to overcorrect it or something because patient again can go to rhabdo. If at all.
So patient can sometimes develop hyperkalemia. That's why.
And creatinine serially, bit by bit, it is increasing. At the day of admission, it was 1.6. Now it has come up to 1.9.
Okay.
So slow, our renal functions are also getting altered. So in this patient, vitamin D supplements were also initiated. And if at all the patient's condition does not improve, then we'll have to go ahead with muscle biopsy and electromyography and looked into other causes of myopathy.
If you give steroid, what will happen in this patient?
Again, glucocorticoids will worsen myopathy, sir. But if at all, we can give a shot of corticosteroids like on a trial basis and see if the patient improves, then malignancy has to be thought of.
So if the patient improves with steroids, then it can be a secondary polymyositis. Polymyositis, not statin-induced polymyositis. So we can only try steroids, but it is not a definitive treatment for statin-induced myopathy. It is only stoppage of drug and wait for conservative management and avoid renal failure when there is rhabdomyolysis. Okay, how is the patient now?
Patient is improving. So the muscle for analgesia, we can give paracetamol. NSAIDs are better to be avoided.
Okay.
If at all patient is having a lot of pain, then opioids can be tried, but low dose opioids.
What about mobility?
Mobility, he's not moving because of pain, sir.
What is your advice? In polymyositis, better to restrict the mobility. You ask the patient to avoid strains. So that will aggravate the problem. It can produce more damage to muscles. So we have to avoid that.
So overall his pain has come down. Analgesia was given. He's on continuous fluid and we are watching him for any fluid overload state also.
Okay.
That's about it, sir. He has improved from the time he's come to he's
So it's a statin-induced myonecrosis.
Yes, sir.
Okay.
Yeah,
Thank you.
sir.